Good morning, everybody. With my colleague, Guillaume Maxant.
Good morning.
We would like to speak about the contribution of artificial intelligence on remote monitoring in the wound care management. So let me first present you Pixacare, a company dedicated to revolutionizing healthcare through innovation. I have conflict of interest in this presentation since I'm co-founder of Pixacare. And actually, I'm the medical, scientific, and ethic responsible of Pixacare. Let me present you the company. Pixacare was founded in 2019 in France with two collaborators. You can see on the photo Mathis Ringdahl, the CIO, and Vincent Marcedus, the CTO. The team have grown up to 20 collaborators, and our mission is clear. We want to transform the care journey for thousands of patients with skin lesions. We have a mobile application and a web application tailored for and by healthcare professionals. And we have held a lot of certification, ISO certification, 2 CE marks, and European patent. Our impact, our solution is trusted by healthcare providers across Europe. 50 hospitals and clinics rely on Pixacare. More than 1 million photos have been taken for almost 100,000 patients. So let me present you the groundbreaking features that makes Pixacare a game changer for wound care management. Firstly, we have a mobile application to take some photos and documentation of the wound. The photo are secured and accessible everywhere for ongoing management. Secondly, we have a web application for remote monitoring from home. And thirdly, we have developed a tool for wound measurement and wound analysis through artificial intelligence. So why Pixacare is interested with remote monitoring? Because we want to enhance the organization of care for chronic wounds. Currently, there is a lack of specialized caregivers, and this shortage leads to high consultation times in expert centers. Moreover, there is an heterogeneity in both specialties and in practices used for wound care. So we observe variability in consultation frequency and in care pathways. There is faults in appropriate cares, interruption in cares, sometimes late detection of complication. Some patient faces progressive risk, including infections, prolonged hospitalization, amputation, and death. The telemedicine have shown is very important for enhancing the care of chronic wounds. Firstly, they have demonstration for teleconsultation and more recently with remote monitoring. The main demonstrated benefits of the telemedicine is the reduction in healing time, the reduction in the number of consultation or ambulance transfer, and in some publication we can find some reduction in the duration of hospitalization or reduction in amputation rates. All these publications goes to one outcome, the overall reduction of the cost. So let me focus on 3 publications concerning the remote monitoring. The first one was published in the International Wound Journal in 2016. It's a Swedish multi-center study. More than 1,000 patients were involved. It was patients suffering from leg ulcers. And the professionals have demonstrated that the promotion of a structured and specialized wound care with regular monitoring of health kinetics can ensure the patient outcomes. The results are striking because the average healing times was reduced almost 50%. It's a reduction cost of the same volume, 46%. So we are convinced that remote monitoring of chronic wounds is able to ensure an optimal monitoring by experts without overloading the limited number of health professionals. The second pivotal publication was in Diabetes Care in 2017. It's another Swedish multi-center study, and it's a randomized controlled trial. 182 patients suffering with diabetic foot ulcer were included in a 12 months following period. The patients were divided in 2 arms. In the first group, 88 patients have had a conventional follow-up with face-to-face consultation every 6 weeks. And in the other group, 94 patients had a remote monitoring with photograph, questionnaire, and communication through mails and telephone calls. All the results are very interesting because there was a reduction in amputation rates of 48%, dropping from 40.8% to 6.2%. The last interesting publication was very recent. It was in the Lancet Regional Health in 2023. It's a French randomized multi-center study. 180 patients suffering from diabetic foot ulcer were included. It was also in 2 groups, a conventional group and a remote monitoring group. And the results are also very interesting because the hospitalization duration was reduced about 50%. It's an annual cost reduction per patient, about more than 3,000 euros. So that is all the reason why we wanted to develop a system for remote monitoring by Pixacare. In one hand, we have a caregiver solution, and in the other hand, we have a patient solution. So the caregiver solution uses the mobile application and the web application. The patient go home with a QR code, and the nurse at home are able to take some photos to analyze the wound with questionnaire. It's adaptable questionnaire if the people want, and it's possible to discuss with messaging. It's a secure messaging. The patient solution is more simple. After the first consultation, the patient have a QR code. It's given through the mobile. And we ask the patient to take some photography every week of the wound. And the patient have to answer 5 simple questions to detect sign of complication. It's temperature, pain, redness, exudate, and odor. When there is a risk of infection, an automatic alert is sent to the expert. So we have evaluated the remote monitoring by the patient and by the caregivers. So firstly, I will shortly present you the study for the patient. We have a preliminary study and a multicentric study. So the preliminary study is for the time during 3 months. It's a little study with 25 patients. The objective is to evaluate the satisfaction of the patient and the satisfaction of the caregivers. But after the most important thing is to know if there is a use of the patient, an adherence or frequency use of this application. It's only patient who can use a smartphone. It's just a part of the patient. So it will be finished in 1 or 2 months. It's a little study in 3 months. After that, in September, we will begin a big multicentric study. It's a randomized study with conventional and remote monitoring with Pixacare solution. And the objectives are third. The first one is to analyze the area reduction at 4 months and to see that there are no inferiority in the remote monitoring mode. And we would like to demonstrate that there is a reduction in duration of hospitalization after 12 months and an augmentation of the quality of life of the patient. This study will be for 2 years, 1 year for inclusion and 1 year for follow-up. So the evaluation of the remote monitoring by the nurse will be presented by my colleague, Guillaume Maxant. Thank you.
Dear colleagues, dear friends, Guillaume Maxant, cardiovascular surgeon, just north to Strasbourg. I'm probably one of the first intensive user of Pixacare, and we had a lot of experience with this system, especially concerning remote monitoring. So, remote monitoring, why do we need to make remote monitoring? It was an optional issue before the pandemics, and I think that today it's a mandatory problem. We have to make remote monitoring, and that had proven that it's safe in all cases, it's frequently cost saving, and it's frequently more effective than conventional follow-up. So, remote monitoring with Pixacare, I think that we will talk about implementation of machine learning algorithm. We can talk about the front end with this WhatsApp-like, which is very simple to use. But the key feature is that you use a QR code as a key to access to the shared files. That means that the patient holds the key and you do not have any registration of primary care nurses, and you don't have to register the consentment of the patient. He holds the key. He gives the key to every care provider you need, and that's a very nice and smart thing to do the thing. You have the so-called QR code. So I started remote monitoring with Pixacare in June 2021. 2 years later, I had collaborated with about 150 nurses, reduced my follow-up consultation of about a third. You will see that it was underestimated. And I increased the accessibility of my consultation to new patients. And I think it's something very important. So we tried to evaluate formally the results we had with this remote monitoring with 3 aims. The first one was to confirm the safety of the remote monitoring. The second was to evaluate the clinical benefits. And the third, to estimate the medico-economic impact. With Pixacare, it was made in a vascular surgery setting, including all type of leg ulcers such as venous, diabetic foot, or pressure associated. We will be brief, and you will have all the data in a publication that was made this month in the International Wound Journal. So it was a prospective, non-randomized study. The patient was located regarding to the surgeon. That means that all the patients are followed were included in the remote monitoring group. The other patients were followed in a conventional follow-up group. It was an intention to treat analysis. That means that remote monitoring was optional and non-mandatory. If the patient required a consultation, he had a consultation. We, on a 6-month period from January to June 23, we included 103 patients, 42 in the remote monitoring group, 61 in the convention follow-up. The true group were overall similar, except the patients in remote monitoring groups that were older. So, what were the results? These were anticipated. That means that we didn't have any difference concerning the safety criteria. No more mortality, major amputation, no more loss to follow-ups, that's important, and no more patients with a non-healed wound at 6 months. We had a big surprise. We constated that the visit to the emergency department was reduced in the remote monitoring group. And the unscheduled hospitalization following this visit were also reduced. We had 1 visit in the emergency department in the remote monitoring group versus 8, and we had 0 days of hospitalization, of unscheduled hospitalization in the remote monitoring group versus 64. So, remote monitoring seems to reduce unscheduled hospital care by enabling upstream management of complication. Unfortunately, the study was not designed to explore this element, and we were not significant. Second part concerning the clinical results. We had the same wound closing rate, but we saw that the average time to wound closure was reduced by 1/3 in the remote monitoring group. Concerning the medico-economic impact, we saw a 55% reduction of the consultation in the remote monitoring group, with something that was statistically significant. We had the same length of planned hospitalization. We estimated the reduction of the wound-related cost with more than 1,500 euros per patient per 6 months. So, we can consider that remote monitoring with Pixacare is safe, and I think it's safer than conventional follow-up if we consider the unscheduled hospitalization. It's clinically more relevant than conventional follow-up, and it's more cost-effective. This is consistent with previous study, which all showed that it was safe. Safe, even if clinical relevance or cost effectivity were more balanced in the 5 previous studies. So we can think that remote monitoring is already the standard of care of chronic wound management. Which are the perspectives? First of all, we have to consider that this study was made with the first version of Pixacare. That means that we don't have the ML machine learning quantification method available. We had a basic front end with a head-to-head chat, no document sharing capability, and it was our first experience in our department. So we think that we have urgent improvement to expect concerning both the methods, that means that we had an experience, we will be able to organize an active patient caseload, to dedicate a nursing team to this management. But also, we will have an improvement of remote monitoring with the management of with the quantification of the wound. In fact, the wider perspective concerns the extension of the field of remote monitoring. We have two types of clinical field that may be involved. For example, we use it in our HERAS program, Enhanced Recovery After Surgery, that allows us to monitor our patients at home in the first 2 weeks after vascular surgery. And we started to make what Professor Armstrong called a foot selfie. That means management, a remote management of the healed diabetic foot ulcer with Pixacare. So, in conclusion, we think that remote monitoring is a standard of care. Remote monitoring with Pixacare in 23 is at least equivalent to other modalities, but very lightweight, user-friendly. And in 2025, we think that we have urgent improvement expected in safety and clinical results.
My part. Thank you. Now let's speak about the innovative process for artificial intelligence. We have worked a lot to obtain an accurate, time-efficient solution to automatically analyze a wound. So we have two processes. The first one is named wound size artificial intelligence, dedicated for area measurement. A second one is named wound type artificial intelligence for content analysis. We want to discriminate the tissue in the wound, necrosis, fibrin, and granulation. So, how do it work? Firstly, we wanted to know what was the goal to reach. In other terms, it's to know what's the performance that the artificial intelligence should have. So we conducted a preclinical analysis with the evaluation of inter-individual and intra-individual variability of wound analysis. So we ask an expert to analyze a wound with 85 photographs on a screen computer, and we do the same work with 6 other specialists, and we compare the results. The error threshold was decided to be 10% of difference, more than 10% in difference of area. So this is the result. It's very interesting to see there is a big difference when you ask someone to do the work and another one to do the work. When for the surface, we have 22% of error. It means that more in this 22%, there is more than 10% of difference in the area measurement. For the fibrin, it was 48%, and granulation, 46%. We wanted to do the same work for intra-individual, it's not inter, it's intra-individual variability. So we do the same work with 25 photographs. The game was this one. 5 doctor specialists analyze the wound, and 3 days after, we ask the same specialists to do the same analysis. And we compare the result with the same threshold error of 10%. And these results are, again, impressive. For the same people, there was, in the surface measurement, 16% differences, 16% error. And for the fibrin, it was 29. and for the granulation 23. So to build the artificial intelligence, the first step was the data collection. We collected the chronic wounds, pictures of varying appearance, as you can see in this slide. The second was the data processing. We built a specific analysis tools, and we asked some experts labeling the wound. They have to limit the wound and clipping the interesting area of necrosis, fibrin, and granulation. The third step was to choose the good algorithm, the most suitable artificial intelligence algorithm, and to train the model until to obtain the optimal performance. So this is what we obtain. You can see an original photography with a chronic wound, a post-operative chronic wound of a breast with a lot of fibrin. So the first artificial intelligence analyzes the surface and says it's 11 quadrat centimeters. The fibrin, the tissue of granulation is represent 26% and the fibrin 75%. A second example on this foot, the measurement of the wound is automatic and says it's 23 quadrat centimeters with 62% of granulation and 37% of slough. So the artificial intelligence could be evaluated in performance. And to evaluate this performance, we compared artificial intelligence analysis versus expert analysis. This is the result. We used the same threshold of 10%. So you can see for the surface, it's 25% of error. For granulation and fibrin, it's 30%, 23%. It could be very, very big, but when you compare the first preclinical analysis, you can see that we reach the intra-individual variability for the content, and we reach the inter-individual variability for the surface. So we obtain our goal. This artificial intelligence was be evaluated in clinical trial in order to obtain the CE marking. It will come in some month, and Guillaume Maxant will present you this clinical trial.
Thank you. Thank you.
After? Oh no. Yeah.
So, what's machine learning? Machine learning is a computer method that allows a machine to learn without predefined rules. Its first iteration was made in 1960 with Rosenblatt. We had then an AI winter that was due to the lack of computing power and available data. And there were a reboot in the late 80s with LeCun, Bengio, Hinton, with what we call machine learning. Was wide application today, management of big data, large language models, and what is interesting for us, computer vision. Computer vision is based on two biological analogies. The first one is what we call a formal neuron. That means it's something that sums the input and give an output if the threshold is overpasses. And of the multi-layer architecture of the visual cortex that became this, what is called a convolutional neural network, which is the basic form of neural network to treat image. So, computer vision in healthcare has an immense potential. We have a lot of projects described with fancy presentation in radiology, in pathology, LLM will work better than us in the next months. And Geoffrey Hinton said in 2016 that we should stop training radiologists now. It just completely advised that within 5 years, deep learning is going to do better than radiologists. It's a fake. Why? Because validation matters. Other businesses works with on-the-fly validation, but in healthcare we have the real problem of patient safety, of ethics, and that drive to a high regulatory attempt with validation requirement to protect the patient. So, in practice, we have many claims, but few proof in computer vision in healthcare. Why should we perform chronic wound quantification? Because we have to go out from this semi-quantitative evaluation. Do we indicate a transfusion on the coloration of the eye? No, but we work every day with a semi-quantitative evaluation of the evolution of the wound. We will be able to make better treatment adaptation in clinical practice, and it's a huge potential in clinical research. So Pixaker developed globally three algorithms. One track that is a semi-automated surface measurement with a clinician-driven segmentation. One size, the same but automated with an automated segmentation. And a third one, which is one type with an automated one content measurement, granulation, fibrins, and necrosis. We have a chaining of this algorithm. You take the photo, one size, delineate the wound, and then one type and one track makes the measurement. This is a modular step-by-step conception which is robust by design. That means that it allows a separated analysis of all the bricks, so the process is interpretable and it may be optimized. What were the objectives of Pixar 1? The evaluation of the three developed algorithms beyond the preclinical studies that were very effective, to show a failure to the limitation and to implement the necessary and potential adaptation. And that was the work of Pixaker to obtain the CE marking. How should we evaluate a test? There is two main objectives. The first one is what we call a precision. Precision is the ability to the test to produce the same value with separate testing. Okay? That means that you have a correlation of the value obtained by two or more independent measurements, even if the values are not true. You may have a systematic error, for example. And precision is related to the capacity of the test to monitor the evolution of the wound. Even if you have an error on the first measuring, if you have an evolution of the measure, that means that the wound had been evaluated. You understand? The second one is the accuracy of the test. The accuracy of the test is the ability of the test to produce a value close to the actual value when she's known, or to the value measured by the reference technique. So it's a correlation of the value obtained by the test and with the value measured by the reference test. You can have a test with a high accuracy, but a low precision. Your mean will be on the target, but in fact, you have a large distribution of the measure. So we made this clinical trial, which is called Pixar 1. We included 42 patients, 3 were excluded, so it was a multiplanar wound. We had two experts that realized independent measure of concerning the surface. The reference measure was the digitized planimetry. That means we make the acetate tracing and then we make a measure of the wound with image J. measure of the surface with one track and semi-automatized measure, and we make the surface with one side. That means that we use the fully automatized algorithm. We also made the same thing with the wound content. We had a problem concerning the references. That means that we don't have today a real test which is coherent, efficient to measure the content of the wound. We selected the expert or evaluation and a post-trial segmentation by expert on photograph. And we made the measure with one type. The statistical method was quite usual with Pearson index of correlation, interoperator to evaluate the precision, between the method to evaluate the accuracy. Following Q and Lie, we used a threshold of 0.9 to consider that we had an excellent correlation. These data will be published in the next months. You will have more documented, more elements available. Concerning the surface evaluation, we had with one track, semi-automated segment measure, an excellent precision and accuracy of the measure. We had with one side some similar things, a bit yes, similar measure. You can have on the right the linear regression that shows that we have deviation on the tallest tools, or the tallest wound, probably regarding to geometrical anomalies. Concerning one type, the measure of the content, the results and the overall population was not satisfying. We had moderate to good precision and accuracy that was similar with the expert eyes evaluation. So we had a real gap, a real difference between this real life results and the preclinical result. We explored the automatized segmentation process with a semi-quantitative analysis. We showed that in more than 60% of the patients, we have an excellent to very good segmentation. But we saw some failures. As you can see, you can see here, excuse me, the picture has been switched. You can see, for example, you remember that we used two independent measures of the same wound. And you can see, for example, in this wound, that the segmentation is perfect. But here we have a real failure. We have the same thing in those two aspects. And we saw that the failure of segmentation was not linked to the complexity of the wound. And we show it was another statistical analysis with another viewer, and we constated that the problem was based on the over or under exposition of the wound. That means that I didn't use flash, and my colleague used systematically a flash. And that's the problem of real life. This underexposure led to a reduction in contrast around the side of the wound edge. So we made a second attempt of statistical analysis of one type after exclusion of the segmentation error, and then we saw an excellent correlation, an excellent precision, excuse me, on the evaluation of the granulation tissue. So we will be able to perform an efficient follow-up of the wound kinesis, and that means that we can say how does the granulation tissue evolve in the wound. Concerning the accuracy, we had the problem of the reference method. That means that without any real method that show us ground truth value of the granulation tissue, it's very difficult to compare with one type. So, concerning the evaluation, the measurement of the surface, we had excellent results with both methods, with results that were slightly superior with one track, semi-automatized versus one size. Concerning the contents, we had good results, only if automated segmentation is okay. But we had failure in the process, and these failures was due to an inadequate input. So the solution that will take by Pixacare is to use a new acquisition process. That means that the algorithm will propose a segmentation. The clinician will eventually correct this segmentation and then validate to alleviate such failures. So, in fact, we have to say that preclinical study doesn't matter. All we need the validation in a real life testing, and we need some scientific publication, and this is a work in progress.